Thanks. Been coming to this meeting for many years. Always a great opportunity to meet with colleagues who are like-minded, and I think every year it builds on itself. I'll do my best to make up time in the air here, try to get us back on track. But I'm going to go back low tech, talk about cranial ultrasound in a little bit of a different way. Disclosures. So we're going to talk about some of the advantages and disadvantages of intraoperative ultrasound, talking briefly about its burgeoning interventional role, which we've heard really eloquently about, and then focus mainly on its use as an intraoperative visualization aid. So similar to what you saw with HIFU or treatment ultrasound, this was really introduced back in the 80s in earnest. And you can see the publications year over year. I mean, in 2023, 600 publications. This is with a search for intraoperative ultrasound in neurosurgery. And so you can see there's been renewed interest in this. So you've heard about this increasing interventional role, focused ultrasound, MR guided. We've heard a little bit about sonodynamic therapy, blood-brain barrier breakdown with the ongoing trials. And so there's a lot that ultrasound can do, but we're going to focus on the kind of dumber ultrasound. So how do I use it? This is a tool that I use really kind of in day-to-day practice. It's there, it's easy. It's a dynamic real-time tool that really is low cost. It could account for brain shift, which is a traditional problem with standard navigation, lack of ionizing radiation, and safety. And so when you compare it to other intraoperative imaging modalities like intraoperative MRI, it's obviously very timely, very costly. Intraoperative CT, which typically doesn't have quite the resolution, can be costly in and of itself. Fluoroscopy would be quite a minimal role in modern cranial neurosurgical practice. So intraoperative ultrasound ticks a lot of these boxes, but it's not perfect. Image quality is very variable. It's operator dependent, and what I've highlighted here is just this limited formal training in the use of ultrasound. We had just a real short course yesterday where we went over some of this. I have colleagues. Brian Nahid has kind of opened up a course where they're teaching this. But unless you've done it in your residency training or really focused on it, it's the kind of thing you may have never used, or if you have, it's so limited as to make your ability to interpret the images and use it in a meaningful way challenging. There's imaging artifacts that you got to take into account, and all that gets better with more use. So gotta go past that. So we're typically using B-mode default ultrasound. You could use ultrasound and also look at blood flow. And there are things that are highly echogenic and things that are low echogenicity. And that's what allows you to determine pathology. So typically kind of meninges, choroid plexus are highly echogenic. Water like CSF or cyst fluid tends to be of low echogenicity, and everything in between. And so when you look with modern kind of ultrasounds, you're able to get really remarkable quality images for lesions that are going to show up on ultrasound, where really distinguishing between the MRI and the ultrasound image is almost indistinguishable. And you're able to see with exquisite accuracy in real time. So these are just some examples of glioma. You could see where these images stand out. Even low-grade glioma, which remains a huge challenge because aside from intraoperative MRI, we've discussed how some of the fluorescence-guided surgery really hasn't penetrated into this area, and there are many low-grade gliomas that are quite hyperechoic on imaging and allow it to stand out, and it can be a real tool to facilitate maximal safe resection in this population, which we know maximal resection or even supramarginal resection is exquisitely important in what is oftentimes young patients. So pretty basic equipment that most centers have in some way, shape, or form. You have an ultrasound machine, of which there are a variety of different subtypes, and then your probes. The workhorse probe is the probe on the far left of the screen. This is what we call kind of a brain probe or a fan-shaped probe that is going to give you probably your best view in an open craniotomy. There are smaller probes for use either through a NICO tube or through any kind of tubular retractor that could be very helpful. So how do I use it? So I think it's exquisitely important for lesion localization, particularly in the subcortical space. You can identify the extent of disease there, allows you to minimize your dural opening, particularly with some of these brain path cases where you may have a craniotomy and may need to tailor your dural opening. You could triangulate where the lesion is, help you to make a small corticectomy, And if you get lost in the subcortical space, which I think has happened to all of us, you put small pieces of gel foam at the depth, which is hyper echogenic. Use ultrasound to kind of help guide you, leaving little breadcrumbs as you advance. And I think this has certainly saved me times in the operating room, and it helped save some colleagues who have been searching for a small calf mal kind of deep in the white matter where everything starts looking the same. Several before me have stressed, as we all know, the importance of a maximal safe tumor resection and using every tool in our armamentarium to be able to achieve this. Image guidance, now fluorescence guidance. And I think ultrasound can play a critical role here because, again, it's real time. And I think things that we need to account for, artifact, blood in contused brain can look artifactual, flow seal or hemostatic material can be artifactual. What you're seeing kind of at the bottom middle picture here is what's called posterior wall acoustic enhancement. So at the bottom of a fluid-filled cavity that's irrigant in a resected cavity, you get that streaking hyperechogenicity, which could look like tumor. Again, the more you do this and you understand what's artifact and what's true residual, will allow you to do that. You know, Dr. Hajibaniz was talking about that overhang of tissue sometimes where we're working underneath, which can be challenging even to visualize with fluorescence because you may not be able to see under there. Ultrasound's a beautiful tool to be able to see that and to be used in conjunction with all of our existing technologies. There have been multiple studies that have demonstrated similar sensitivity to residual tumor from intraoperative MRI to ultrasound. And that has a very high positive predictive value and negative predictive value when the lesion is identifiable. And so I think an initial sweep with the ultrasound, which shows that, hey, I could see this. This is what it looks like, even taking a freeze frame of that so you have it for reference to know that you could visualize this could be very helpful. And again, these are just some images. Your low-grade glioma on top, primary glioblastoma, and then recurrent lesions that you could identify on imaging here and help do a nice resection. So I'll briefly touch on just some advancing techniques. I think there's been a lot of excitement about integration of ultrasound with navigation. And there are a variety of navigation platforms that allow for this and a variety of ultrasound platforms. But I think this is the kind of tool that's going to help a lot of neurosurgeons who don't have comfort with ultrasound really overcome that. So you're able to do this in 3 dimensions. You're oftentimes able to update your registration based on brain shift. Could be really quickly integrated into the workflow. And again, I think help 3D visualization of the tumors in the way that you're used to thinking about it with standard MRI and CAT scan imaging. But it hasn't really made it to the US in the same way it has in Europe. Contrast enhanced ultrasounds is similar, putting these micro bubbles injected through the IV, probably enhances visualization of residual tumor, particularly enhancing tumor. Could be synergistic with 5-ALA and is another tool that I think will slowly start making its way to us. Sonolucent implants, I think, the future for potential longitudinal visualization of tumor, and again, opening up an even broader window for treatment in the postoperative setting or the recurrent setting. There's a lot of interest there. This is one of my colleagues has started a company. This is in particular initially going to be used for placement of external ventricular drains. So it's through a perforator hole, this mounted ultrasound that does a scan, and they have an AI algorithm that will digitally reconstruct the ventricle and allow you to align a trajectory and target the ventricle. They're looking at the same technology for ICH. As everybody stressed this morning, the importance of volume reduction of the ICH, minimal ICH volume, that maybe an initial sweep to calculate the volume, a sweep at the end to see what you're doing. Again, another kind of subtle but interesting advance in just use of ultrasound. So talk basically about the parafascicular approach. I think you've heard about this kind of this morning. Those who were at the course yesterday saw this. Fairly standard approach that I think that the beauty of which is the standardization that we're all doing this reasonably similar and helps kind of minimize that surgical difference when doing clinical trials and when treating patients. And so, you can augment this MIPS approach with ultrasound, and I use it at a variety of points throughout the case to both identify the sulcal entry point and confirm the localization of the tumor. We use it to when you've docked the tube and you may not directly visualize the tumor as a wanding technique, which will show. and then also to identify the extent of resection and do an iterative resection. So you can see this is, before the dura is open, you've identified a sulcal entry point, seen where the tumor is. The traditional fan-shaped probe, you're able to then open the dura right over there. You could use Doppler ultrasound to identify these areas, doing your sulcal opening. Now you can confirm the visualization of the lesion so that when you have the tube docked, I think what you can see here is kind of the base of the tube here is a thin rind of tissue, and you have the tumor below. So when you're looking at that white matter and you're not sure where you are and you think your navigation may not be on, this is a nice way to do that. Are you able to play the videos? Yeah. So this is what we call kind of a wanding technique. You see the tube in there. You're looking at a cuff of white matter. You have the probe. You put your irrigant in there, and you're able to move back and forth to ultimately identify the lesion. If you could just play the video next to it, and kind of that's what you're seeing. So in real time, you're able to move it. You see, I may need to re-angle my tube. It could be very nice technique, especially when you have a small craniotomy, or you feel like your navigation's off. So this could help. And if you just play this, so, and again, for assessing extent of resection, right? So you've completed your resection. This is using, the dual suction technique with the myriad aspirator and suction, pulling out a metastasis. And then at the end, you're able to look with the ultrasound after you've done your hemostasis to assess for any residual disease. And I'll show just a brief example of that. This is a lung cancer patient with a right frontal lesion. You've taken a traditional kind of right frontal approach. There's your initial ultrasound where you see the lesion quite vividly. This is the same picture we saw before. But this is this following removal of that small chunk of the tumor. You're seeing a small bit of residual here. You're able to go back in, resect it. You're seeing the hyperechoic flow CO and irrigant floating around in there, and to know that you've had a robust resection. So I will thank everyone and end there.